Hello, welcome to the Woodland, everyone. My name's Andre Tomlin from the Mental Health, and it's my great pleasure to warmly welcome you to this webinar. It's the MHNR2019 conference webinar. That's the Mental Health Nursing Research Conference. And we're meeting today to talk about the 25th International Conference, which is taking place in London in September, on the 12th and 13th of September. This is a really great mental health event. I can say that as somebody who's been to the last few years in Nottingham and Cardiff and Manchester. And yeah, really looking forward to this conference in September in London this year at the RCN headquarters. And the theme of the conference this year is From Global to Local, Mental Health in a Connected World. And the webinar today is going to feature contributions from a number of people who'll be giving lectures and keynotes at the conference in September. I'm just going to quickly introduce them, and then we're going to go around and have some conversations. So we've got Professor Ben Hannigan. He's Professor of Mental Health Nursing at Cardiff University. Dr. Dilma Yearwood, Associate Professor of Nursing at Georgetown University in Washington, who's joined us at the crack of dawn. So thank you, Edilma, for that. Professor Sue McAndrew, she's Professor of Mental Health and Young People at the University of Salford. Professor Fiona Nolan, she's Clinical Professor of Mental Health Nursing at the University of Essex, and also Visiting Professor at the Mongolian National University of Medical Sciences. We've got Rick Burgess from Recovery in the Bin and Manchester Disabled People Against Cuts, and also Bethan Edwards from Recovery in the Bin. And finally, Professor Ricardo Araya, who's the lead of Global Mental Health Research Group and the Director of the Centre for Global Mental Health at King's College London. So I'm going to hand over first of all to Ben Hannigan. He's the chair of the MHNR 2019 conference. And he's going to give us a bit of an overview of the conference and tell us what to expect.
Okay, many thanks, Andre. Hello, everybody. So this is a really important International Mental Health Nursing Research Conference. Not only is it our 25th, people familiar with the conference might remember that until a couple of years ago, we were the International Network for Psychiatric Nursing Research. We changed our name to become the International Mental Health Nursing Research Conference, maybe three or so years ago. But it's our 25th meeting, and it's special because it's a quarter century. It's also special because it's the first time that we will have met as a conference in London. We've organised this annual event with the Royal College of Nursing. We've always done that. And Mental Health Nurse Academics UK, which for the last 5 to 10 years or so has been a key part of making the conference happen, have together, the RCN and MHNR UK, made the decision to meet in London. And also, and this is Edilma, when you come to speak and to tell us a little bit about what you're going to be talking about, we also, and we've never done this before, we've partnered with a third organisation. And the third organisation is the International Society for Psychiatric Mental Health Nurses. And Edilma is a past president of ISPN. So in London for the first time, having our quarter century, and also for the first time having a conference organised by three different organisations. Let me tell you a little bit about the theme that we're running with this year, which Andre, you've already just trailed for us. So our overarching theme is From Global to Local, Mental Health in a Connected World. We're interested this year in receiving abstracts and hearing from people talking about mental health all around the world. And we have a number of sub-themes. Let me give you a flavour of what they are. And this is important for people who are still looking to submit their abstracts for concurrent presentations or for workshops, or for posters. We've got another week to go before our abstract submission deadline is reached. So our first concurrent theme is promoting mental health and preventing mental illness. And we're linking that theme to Sustainable Development Goals for health. So we're interested in hearing from people who will talk to us about population and community level determinants of mental health and mental ill health. We're interested in people able to talk about joining up mental health and mental health provision across different sectors, agencies, and organizations. Our second theme is capability, capacity, and creativity. So here we're interested in, for example, evidence-based mental health interventions for people with commonly experienced mental health difficulties, and how that might be organized in low and middle income countries. We're interested also in capability, capacity, and creativity in parts of the world where mental health systems have had opportunities to be more developed, to be invested in. And our third theme is around rights-based approaches to mental health. And we're interested here in people presenting, talking to us, sharing their ideas, their research, which is around a shift, if you like, towards mental health as a human right and a human rights approach to mental health service provision. And that's probably a reasonable enough overview, I think, of the conference. The key thing to say, I think, is that we have one more week. I'll say it again, one more week for people to put their abstracts in. That won't be lost on people. That's actually Easter Monday. That's not a mistake. I think on Tuesday, the day after Easter Monday, which here in the UK is a bank holiday, the work will begin on pooling together abstracts for presentations that people have submitted, and they'll come out to the scientific committee probably towards the end of next week. So for people who've perhaps been used to the conference extending its deadline, I wouldn't rely on that this year. So people listening to this webinar with something to say in the area of from global to local, get your abstract in the next 7 days.
Great, thank you, Ben. That's a nice call to action. Get your abstracts in, everyone. And we've tweeted links to the conference website. So if you want to find out a bit more or book a place or all that kind of stuff, then please follow those. Okay, so our next speaker is Edilma Yearwood. And Edilma is joining us from Washington. So thank you very much for missing your breakfast, Edilma, for this. You're going to have to rush off to work fairly soon. Right. Tell us a bit about your work in global mental health and your perspective on this discussion.
Yeah, good morning. I'm really glad to be joining all of you. And I am an immigrant from Panama. So I was not born in the United States, although I've lived in the United States pretty much my whole life. I have become incredibly intrigued and actually motivated by this entire topic. And several years ago now, I think in 2017, my colleague, Vicki Hines-Martin, who is the current, will be the incoming president of ISPN, and I developed and wrote a textbook on global mental health nursing, which is carried by Routledge. And so the other piece of what has motivated me is the entire Lancet series that's coming out primarily from the UK with Vikram Patel. And I've had a couple of occasions to meet Vikram, and he actually wrote the foreword to our textbook. So I am a real follower of that entire group of researchers who have been working on this global mental health movement since about 2007. And so one of the things I'm going to be presenting in London is just an overview of where we are right now and why this is so incredibly important right now that we have a global voice and that we join as a global nation to tackle the mental health crises that's part of every single society and country. So the things I'd like to sort of focus on at the conference is the whole issue of low, middle, and high income countries, and a little bit of a profile of those groups, but also looking at and talking about how do we what are some common elements that we need to sort of insert in all three of those areas, low, middle, and income, in our work in low, middle, and income countries? And so the things that I'm sort of struck with is the lack of attention on our part as academics and researchers to mental health literacy. So I'd like to sort of focus more on mental health literacy and what that might look like in each of these groups. And also very, very much a fan of task sharing that the Lancet series advocates for, because I think the issue of mental health literacy, increasing mental health literacy, and working in communities on task sharing, which is to help to develop the workers within the community, will hopefully help to decrease some of the mental health stigma that we're dealing with. So I'm a strong proponent of those pieces, and really working hard to increase what people know about mental health and mental illness, and how we can work within communities in a culturally sensitive and tailored way to increase what the community members know about mental health and well-being, and how we can all join together, the academics, the researchers, and community consumers, to tackle this very, very, very big problem that unfortunately is getting more problematic within society. So that would be my focus. I also want to sort of spend a little bit of time talking about nursing. Currently, we have about 21 million nurses around the globe. And so nurses in the US, we annually do a survey of who consumers trust. And for the last, I think, 16 or 17 years, consumers put nurses at the top of their trust list. So I think that's an opportunity for us to leverage nursing globally to do some of this work. And I think what we need to try to do is work on how we can come up with some really unique strategies to use nurses globally to carry some of the message also, and to help to decrease the stigma around mental health and mental illness. So that'll be the focus for my talk in London.
Thank you very much. Any questions from our panelists for Edilma? I wanted to ask if you had an example about task sharing, because I think a lot of people won't necessarily be familiar with that. Can you give us a practical example of how that works on the ground?
Yeah, one of the things that they're doing in, I think it's Gao, India, and this is through Patel and his group, and when he was in London, he's now at Harvard, is that they went into the community and trained community health workers, people in the community, to understand more about mental health, and to actually go into the community and talk with and do the assessment, and then do a handoff to the practitioners, healthcare providers, when they had some concerns about someone who was struggling with a mental health issue. So it's really training your community members to understand mental health and to be the cultural broker, as it were, in the conversations around mental health, because they're more trusted. We are sort of in those spaces and not necessarily trusted, because we are usually bringing news that people don't want to hear, or sometimes our go-to intervention is medications. And in some of these communities, medications is not what people want to take. And so the cultural broker, which is the community worker, is the person you train to carry this message and to help you deal with the community and have the conversation with the community's members. Yeah.
I think we'll be coming back to this in Fiona's talk and in Ricardo's talk as well, because they're both focusing on global mental health. I wondered if Fiona and Ricardo, you had anything to add to that, or any other questions for Edilma? Oh, hang on, Ricardo, let's just unmute you.
The only thing to say is that thanks for your review, Edilma. I come from a similar country as yours. I come originally from Chile, so we both share the same language. We're not going to speak in Spanish now, and don't worry. The only thing to say is that, you know, the ideal thing would be that we don't say the same things. I mean, personally, I wanted, you know, well, most of my working life has been sort of trying out different things in different countries, poor countries. And essentially, it's this idea of task sharing. So maybe, I mean, I can concentrate on a number of the examples that had been, well, successful, and the failures too, why not to say that? And then there are a few of those who kind of sort of hit the headlines more recently, like the Friendship Bench in Zimbabwe, that I was a senior investigator on that. And perhaps, you know, sort of give example, but I wanted to sort of cancel most of this thing, the task sharing is sort of split among a number of people that they all belong to a team, a health team. And in the health team, you know, very often there is a nurse. In fact, in many of the African countries, there is only a nurse. There are no doctors. So the nurses do the whole thing. And perhaps, you know, people will be interested to hear a little bit more about the role of nurses in some places, you know, in Africa, where nurses really run the whole show, from prescribing medication, making referral to, you know, providing psychotherapy and the whole lot. So essentially they've replaced the doctor. And probably, I dare to say that that's probably the case in most of the African countries, with the exception of South Africa, I guess. So I want to sort of, you know, more, perhaps, you know, I can concentrate more on examples of the intervention, the projects that I've been involved in, what I've learned, and can sort of talk a little bit more about the task sharing in terms of spreading it out and the various options that are available in different settings. But the common is, you know, how do we do this in such a way that we don't clash and then we don't repeat the same thing and bore the audience. I'm not sure what Fiona is going to say, but
I mean, I can focus more on the overview of what that is, because you have more examples. That would be great. And I can just very briefly touch on it as a part of what I was going to talk about. So I could dial it back a little bit.
I think I'll be talking specifically about a case study, so it will be a specific example. So I don't think it will overlap with what you've got to say if you set the scene, and then I can drill down into specific example. But I won't be talking so much about task sharing, so that element won't be covered in my case study. It would be more about, well, I'll tell you more about it later, but more about the nursing component and the role of nurses in a low-income country and the potential for development of that role.
Okay, that sounds great. Thank you, Edilma, for previewing your work for us. Let's move on to Sue. Sue McAndrew, who is giving the Mental Health Nurse Academic lecture at the conference in September. Sue is Professor of Mental Health and Young People at Salford University. Over to you, Sue. Do you want to tell us a bit about what you're going to be talking about in your lecture? Oh, hang on, we can't hear you.
Can't hear me.
Now we can hear you.
Okay. So the title of the lecture is Connect 3, Winning the Game by Exploring the Mental Ill Health Connections between young service users, adult users of services and young carers. And over the last few years, mental health guidance and policy here in the UK has not only recognised the widespread nature of mental illness across the UK, but it's also started to acknowledge the way in which it affects people throughout the life course. An emphasis is now being given to prevention and early intervention, focusing on the causes and progression of mental health problems using a life course approach. In the main, the paper that I will be delivering will focus on the mental health of young people, both in terms of them being service users and carers. And evidence at the moment suggests that 3/4 of all mental health problems are established by the age of 18, with 1 in 8 children aged 10 to 15 reporting symptoms of mental ill health. I think developing a mental health problem at a young age can have lifelong adverse consequences, affecting emotional, social and educational development, and subsequently chances of employment. Likewise, research also suggests that 29% of people diagnosed with a mental illness are being cared for by a young person. And there's an estimated 1,700,000 young people living with a parent who's experiencing severe or enduring mental illness. In the UK, parental mental illness is a significant factor for children entering the care system. And it's been estimated that between 1 and 2/3 of young people whose parent has a mental illness will also experience a mental health problem themselves. So in the paper, what I'm going to try and do is bring together 3 small qualitative research projects, all using a narrative approach to further explore the interconnectedness of these 3 groups of people. During the lecture, there'll be a number of personal narratives of young service users and adult users and young carers, demonstrating how such stories might be interwoven in terms of mental illness. So I'll be using 2 theoretical frames, that of psychoanalysis and humanistic theories, and the onset and long-term consequences of mental ill health for these 3 groups of people, and also the implications it's had on their lives, and that's what we'll be discussing. The audience will be prompted to consider what needs and could be done, both individually and collectively, for preventative mental health care. Consideration will also be given to how, as mental health professionals, we can refocus in order to make serious inroads into providing more cohesive and effective primary and secondary mental health care, in particular into the lives of children and young people. The significance of the lecture, I hope, is its relationship to contemporary policy, whereby rather than sustaining the status quo of responding to diagnosis, as mental health nurses, we rethink our position with regards to the way forward for the delivery of mental health care and the role we could play in that to promote and enhance the mental well-being in terms of practice, education, research and policy in the 21st century. So we improve the chances of children and young people to becoming healthy, happy citizens. So that will be the basis of the lecture, looking at these 3 groups of people and looking at their interconnections in terms of their mental ill health.
Thank you, Sue. That sounds really fascinating and amazing timing, I think, for this lecture, given that youth mental health is something that is now kind of core part of our mental health discussion.
And something that's in schools, the government are looking at to introduce by 2020, I think, to all schools, certainly throughout England.
Yeah, absolutely. So the way that we deliver care for young people is changing quite a lot, isn't it? And I suppose also the kind of interest in research funding. So Wellcome just announced a few weeks ago, didn't they, their new mental health priority area, which is focusing on young people, common mental health conditions, that Miranda Walpert is leading. I wanted to ask, how do you think that, it's very early days for that priority area, but your kind of research, this kind of qualitative research, do you think that's an area that's going to be invested in as much as it should be compared to the other sorts of research that we see in young people?
Yeah, I think it's I think there's 2 things. One, mental health research always seems to lag behind other types of research. And also, I think often funders are in this mindset that they want a quick fix rather than looking at longitudinal studies, which I think you need to focus on more in terms of qualitative data, and certainly with children and young people, we have to wait to see the effects of what we've done and what implications that will have in later life for them. So I think I would hope that they would go down the road of looking more at qualitative research, but I think it's also fingers crossed that they will do that.
Interesting. Anybody else want to ask a question of Sue or add a comment? Ben, yeah.
Okay, I'm unmuted. Just on qualitative methods, I think there are opportunities for qualitative researchers to get funded, actually. I think it's, or certainly opportunities for researchers who are combining their methods. I mean, the National Institute for Health Research, Health Services and Delivery Research Programme has definitely funded qualitative mental health studies, or mental health studies where people have used combinations of quantitative and qualitative methods. So I'm a little bit more optimistic maybe on that front. That's the first thing I want to say. The second thing is just to note, Andre, when you were introducing Sue, I'm glad that you mentioned that Sue is delivering the annual Mental Health Nurse Academics UK lecture. So for people who don't know about this, this will be so when we meet in September, this will be the third year that there's been a Mental Health Nurse Academics UK lecture. The conference organising committee and Mental Health Nurse Academics UK a few years ago thought it would be a really nice idea to designate one of the keynote lecture slots as an opportunity for people to either submit their own nominations to give that lecture, or indeed to be nominated by others. And we thought it would be a really good idea for that lecture, that annual lecture, to carry the Mental Health Nurse Academics UK name. MHNR UK, Fiona and myself are vice chair and chair respectively, serving our terms of office. And we're representing at the moment, I think, about 66 universities in the UK where mental health nursing or mental health nurses are educated, and or mental health nursing research is undertaken. So we're on the committee, we're really, really pleased that everybody, all of you are delivering keynote lectures. But just to note that, Sue, yours is the MHNR UK one, which is a little different, I guess, from the way in which keynotes are organised elsewhere. That's it, really, I think. But you're all equally, really pleased that everybody will be speaking. But that was all I wanted to say.
Yeah, thank you.
Great, thanks, Ben. Yeah, really interesting topic and really interesting approach, Sue. So yeah, we're all looking forward to hearing what you have to say in the lecture. Okay, so let's move on to Fiona. Fiona Nolan. Fiona is clinical professor of mental health nursing at the University of Essex, and also visiting professor at the Mongolian National University of Medical Sciences. And Fiona's talk at the conference is going to be looking at her work developing mental health nursing in Mongolia. So yeah, Fiona, tell us a bit about this.
Okay, well, my talk is going to cover a couple of strands. It's accidentally about mental health nursing because that's the most recent development, but I think I'm going to give an overview of how I became involved in Mongolia as a case study for a low-income country, really. And again, that was by accident, and that was part of an NHS delegation when we went 2014 to see if there was business to be made, if there was any money to be made in giving consultancy to a soon-to-be rich country. And we thought Mongolia was going to be very wealthy because of the mining industry, but it wasn't. It never came about. So my involvement has been to look at ways of developing mental health services, really, and not specifically nursing, although most lately I've been more involved in a project that's looking specifically at nursing. So I'll talk a bit about Mongolia because if people are like me, they won't really know where it is and anything about the country. So it's a very strategically placed country in the middle, right, landlocked country in between Russia and China. a huge landmass. It's about the size of Western Europe. It's the least densely populated country in the world. I think it only has about 3 million people, and most of them, well, 1.3 million live in the capital city. So until recently, the population was nomadic. These were people who lived in gars and tents until about 50 years ago. And there's been a huge influx into the city, particularly over the past 20 years. So that's incurred a lot of problems associated with urban migration and loss of a traditional way of life. So very interesting combinations and culture there. And the prevalence of mental illness and mental health problems is unknown, really, because there haven't been any surveys following good guidelines that have estimated what it is. But from my own experience of being in the country, they have one big hospital that looks after people who are largely not detained under the Mental Health Act. They do have a Mental Health Act in operation in the country. Most people in the hospital are informal patients, but there are high levels of coercion, and the ratio of nurses and doctors to per head of population is quite high, actually, in mental health. But the difference between pay in salary between nurses and doctors is really low, and there's huge stigma associated with mental illness, and also huge stigma associated with working in the field of mental health. So these are things that I hope to explore a bit in my talk. Very interesting in the inpatient services, they have 40-bedded inpatient wards, which is reminiscent of when I trained early on in mental health. But on my last visit to the hospital, they had gone up from an overpopulation of 55 per ward in a 40-bedded ward to 70 or 75, and that was with one nurse to 70 patients. So we have no idea what it's like to work under those conditions. And I think when we look at how to make improvements and how to assist people in developing their levels of knowledge and skills in these countries, the resources that are available to them sometimes are so limited that even with the most highly skilled professionals in the world, the impact they can have is very limited. So that's going to be one aspect. The second aspect of my talk is going to talk about this project I've just received funding for from the European Union. I luckily got in before Brexit and got €1 million from the EU, which we won't be entitled to go for that kind of money quite soon. But this is it's a very important project for Mongolia. It's to develop postgraduate mental health nursing, because at the moment there's no specialist training for people working in the field of mental illness. So it's not alone. I mean, we have places like that in the so-called developed countries as well, where specialist training for people working in psychiatry is limited. So this project is a 3-year project with partners in Europe. We've got Finland, the Netherlands. I'm leading it, based at the University of Essex. And the aim of the whole project is to put together a 1-year postgraduate diploma for nurses to equip them to work in mental health settings. A large part of the program is to enable them to visit our services in the EU as well. So, well, in September, I'll be able to talk a bit more about the visits, but we've got one coming up in a couple of weeks. So we have 15 Mongolians coming to London in 3 weeks' time. And for almost all of them, that'll be their first time out of the country. So there's been they've all had to buy passports, and they're all in the process of getting their visas at the moment. And none of them, not one of them, speaks a word of English. So the challenges in dealing with low-income countries, there's culture, there's resource, but the language for places like Mongolia is a huge challenge. So with this visit to London, for example, we've got one interpreter. The cost of interpreters is really enormous, and trying to facilitate a week-long visit for these clinicians to get the best out of the hours that we have with them with one interpreter is going to be quite a task. But over the 3 years, we'll have a pilot group of students who come to the EU for periods of 2 weeks each to work in our clinical areas. So they'll bring that knowledge back to Mongolia with them. Another aim of the project is to raise the status of mental health nurses, and I think Mongolia isn't alone in being a country where the status of nurses is very low in the healthcare industry. Even though there's very little pay difference between nurses and doctors in the hierarchy, it's well, I trained in the 1980s and things were different then to now in the UK. And there was a very big gap in status between nurses and doctors in the UK then. It's lessened now, but in Mongolia it's really enormous. I've never seen a nurse speak when a doctor is present, and nurses stand up when doctors enter the room, that kind of thing. So I think yeah, addressing the low status is going to be a huge task. So my talk is going to echo some of what Edilma says, but be more of a focused case study and focus more on the role of nurses.
Thank you very much. I'm really interested in how you got into this. You're saying this is a kind of chance encounter almost, and it sounds like you're really kind of excited and committed to the work now. Well,
yeah, it's been a privilege, really. I think it was an accidental discovery, but I think as a nurse to be able to lead something like this is quite unusual. Most of the work in global mental health is led by teams, which are led by medics. And Ricardo, I'm sure you'll be able to talk a bit more about that. But I think to be a nurse leading a fairly large project and a nurse leading a program of work in a country is unusual. And I think that's important for role modeling as well. I think most people think I'm a doctor in Mongolia, and I really, like to emphasize that I'm a nurse and a mental health nurse. Yeah, so it was accidental, but it's been fascinating and very, very challenging.
I can imagine all those, she can't be a nurse, she's talking like a doctor comments. Yeah.
Oh, yes. Yeah, although being a man, when I go with my male colleagues, it's different again, because they're absolutely incredulous that a man could be a mental health nurse. And in our EU partnership, we're about half in terms of gender balance, and that's nice in terms of role modeling as well.
Do you want to come in, Bethan?
Gonna ask, I was wondering whether the status between doctors and nurses was based on the gender of nurses and doctors.
Yeah, it's not really. I think the majority of doctors are also women. About 90% are female. So the healthcare industry is very feminine, female-based in Mongolia.
It's interesting.
Any other questions or comments for Fiona?
Fiona, I'm really interested in what your curriculum will look like, and I can't imagine, not having any direct experience of mental health nursing or mental health care in a lower middle income country, what that would look like, where the kind of assumptions I might have in my head around service availability, the way in which mature mental health systems are organised, just don't hold true.
Yeah, and well, that's a huge issue. I have no idea what it's going to look like, and that's part of the challenge. The first 18 months of the project will be developing this curriculum. So we'll have curricula from all over Europe and wherever in the world I can get basic curricula to look at what other people are using, and then try and hone it down to what's appropriate legally in Mongolia and culturally and within the resources available. Because they have no community mental health services, for example, even though it's part of their strategic plan. So I think equipping mental health nurses to work in the community, while good prospectively and a good aspiration, it won't really help them right now. So these things we need to take into consideration. But it's a massive task to try and come up with a one-year program that's fit for purpose, but yet covers everything that Mongolia needs.
Great. Thank you very much, Fiona, for sharing with us. Looking forward to hearing more about that in September. And yeah, good luck with all the meetings in London. You make sure you show them a good time, as well as try and understand what they're saying through those 2 weeks. All right, so let's move on. Let's have Rick and Bethan. So yeah, really excited to have Recovery in the Bin at the conference this year. Rick Burgess from Recovery in the Bin and Manchester Disabled People Against Cuts, and his colleague Bethan Edwards, also from Recovery in the Bin. Yeah, tell us what you're going to be talking about in London in a few months' time.
Well, I feel like we're a bit like the spectre at the feast. You know, we're from a perspective of wanting to develop more a social model of mental distress. And, you know, one of our key images is the unrecovery star. We've repurposed the recovery instruments to talk about not what affects the individual, but how the culture one's within, the political economy one is within, affects you, and how that causes mental distress. You know, the reality of the UK at the moment is both migrants and asylum seekers have been subject explicitly to a hostile environment by the government, and disabled people have explicitly been subject to a hostile environment by the government. The already very high suicide attempt rate in benefits is, since the measures that have come in for the last 10 years or so, that already very high rate has doubled. So there's those issues. There's the issue that I would, while there are good initiatives, there's good bits here and there. Overall, I would say that the United Kingdom doesn't have a working mental health system. We don't have a system where someone can go and get help and be guaranteed it's going to be good and it's not going to harm them. That just isn't happening. And it is a consequence. We're at the sort of the tail end of 4 decades of neoliberalism. We're approaching an environmental crisis as well. People are distressed because the system distresses them. And so when we talk about going out into the world, you know, Britain by and large is a global villain. Colonialism, wealth extraction, etc. Are we going out into the world? Are we exploiting people more again? Are we taking best practice from here? Or, you know, should we be listening as well? And should we be realizing where we've gone wrong in this country? Because it's not working at the moment. It really isn't. We persistently get reports of the most terrible neglect and abuse from a system which seems to be built largely to fulfill management metrics, and the service user, the person, is more like a cipher to create this data that can then justify what everyone's doing. But the welfare, the well-being of that person seems almost secondary. So I think there's a real feeling that we want to talk to the people around the world as well, subject to their systems, and find out from them what their experiences are and what they would like, and to acknowledge that there's a problem in the UK that is from the top because of this decades-long drive of neoliberalism towards privatizing, deregulating, and turning the individual into a market actor as opposed to a human being.
Thank you. I know this is going to go down a storm at the conference, having been to a few before. Bethan, what do you want to add to that?
Well, I was just here to support Rick, really. So I just want to add a little bit about recovery. We're not researchers. We are a group of service users and supporters, people with lived experience of mental health conditions. Rick's cat is meowing. So that's just what perspective we're coming from. We are coming from a lived experience perspective. We have several hundred people in our online group, and we have lots of contacts and networks around the UK. So it's really just to reiterate what Rick has said. We'd like to learn from what's going well elsewhere in the world, rather than go out and maybe yeah, we just want to learn where things are going well and how we can learn from them in the UK. So if I just give a little bit about Recovery in the Bin, so we're critical of how recovery, which was a user-led concept, has now been co-opted by professionals, by policy and by services. And so it no longer is true to its values in terms of how it's being implemented in practice. And as Rick has alluded to, we are currently living in a socio-political environment that has for decades been influenced by neoliberalism. And that emphasises the individual, economic efficiency. And so the initial values of recovery, which was based on collectivism and user-led, no longer fits with where policy directives are coming from for mental health, which is based on this neoliberalism. So the way it's being implemented in services at the moment does not reflect the true origins of recovery. And so we've developed our own Recovery Star to challenge the way recovery is being implemented and ideas about recovery in services today.
Brilliant, thank you. I think it's wonderful that you've got this kind of platform. So I've kind of followed Recovery in the Bin since it started, I think, and been really interesting to join in with some of those conversations on social media that you've kind of spearheaded. And it's great that you're coming to this conference. And I wondered what that kind of means for an organisation that is service users and survivors and activists, like you say, coming to an academic conference and presenting this work. What does that kind of, does that change who you are and what you do?
Sorry, we'll go on, Bethan.
No, sorry, the sound is a bit odd at the moment. All I was going to say was, no, it doesn't change who we are. I was initially approached for this presentation, and it's not, our organisation is not about people, it's a collective, and therefore I was adamant that I wasn't going to go and give a presentation on behalf of Recovery in the Bin. So Rick will be accompanying me, and we will also have someone else who will be coming, and we will be delivering the lecture as a collective. We are just vehicles to spread that message. It's not about me and Rick, it's about our ideas and our theories. And we are incredibly honoured to be invited to speak at the conference, because it means that our voice gets heard, because we're not funded, we're not professors, we can't write journals for the Lancet or whatever. So being able to have a voice at this prestigious conference is extremely important for us. So yeah, and we'd like to start a dialogue about our ideas and things like that. So I think it's great. What do you say, Rick?
It's good that, you know, you're opening yourself up to these other voices, these other perspectives. Because I think actually listening to other people speak, that, you know, when they're in their studies and they're going to other countries and stuff, you're having to open yourself up to other ways of doing stuff and other experiences. So that should always be how people progress everywhere. So yeah, you know, hopefully people will get some value out of it, or I don't know, not throw things at us.
There's been some really amazing kind of lived experience presentations, if you want to call them those, at conferences over the last few years. So yeah, it's great. I think that the conference is really making sure that voices of people with experience are being included. So important at mental health events, but particularly at mental health nursing events, I think. Any other questions or comments for Rick and Bethan?
I'll just echo exactly what you concluded with there, Andre, actually. I'm really pleased, you know, the conference committee is really pleased, Rick and Bethan, that you're coming along. And I think that the MHNR conference has always been a place. Hello, Kat. The conference has always been a welcoming one for people with a whole plurality of views. You know, I think we embrace the idea that mental health is a very contested field. You know, so it will be really good to hear you speak and to engage you in conversation in and around your main keynote. So thank you.
Thank you for asking us.
So there's something you said there when you were talking, both of you, about learning from international settings rather than kind of going out and, you know, being the white man teaching, which I think is, like, you know, obviously a key component of any kind of global mental health work. And Ricardo mentioned his Friendship Bench project earlier. I'm going to listen now to Ricardo Araya. So maybe we can bring that back into the loop. I think that's a really interesting example of an intervention that has kind of informed a lot of work outside of where it was developed, and there's certainly a lot of people in the UK have been really inspired by that. So yeah, Professor Ricardo Araya, he leads the Global Mental Health Research Group at King's and is the director of the Centre for Global Mental Health. Ricardo, tell us a bit about your work and what you're going to be talking about at the conference.
Yeah, well, I suppose that, you know, there are a number of things that people have said that touch on what I wanted to say, because if there is something that really a common denominator from poor or so-called low and middle income countries now, it's the lack of resources, really, which is a kind of a fairly relative kind of construct, because the resources are finite anywhere in the world. You know, people here in the UK complain about not having enough resources. So everywhere, you know, people are saying there are not enough resources, and it touches on what Rick was saying, actually, that, you know, it's a society, we've built societies that, you know, they don't really care about human beings, you know. They're not prepared to pay for their basic needs, one of which is health. Not even to mention the social needs, and there is everything open for competition. And in fact, you know, one of the things that it wasn't mentioned, and I think I'm not the best person to talk about this, but very often when I go to other places, people complain about rich countries poaching nurses from poorer countries. And it doesn't take long before you have to go to any health service here in the UK. And most of the nurses, you know, are not UK nurses, you know, come Philippines or, you know, whatever, you know, the countries where I have to go and work and where they complain that they don't have the resources. And, you know, it started with the doctors, you know, now there are no doctors, you know, it's like sort of, you know, getting rid of the rainforest. There are no doctors. Now, you know, we got nurses, you know, well, okay, we're going to take the nurses too now. So there is an issue there, you know, that to some extent it would be important to, at some point, say, you know, and what is the reality? Well, what is the reality? You know, I can tell the reality in those countries, and it would be interesting to hear about what is the reality of overseas nurses coming to work in the UK. But anyway, it was an issue mentioned. What I wanted to say, it was that, you know, the central thing when it comes to low and middle income countries is the lack of resources. So when I went there, what I was interested in is what can be done to improve the mental health of the people there. And then you have to start from a, you know, a very, very low in terms of resources. So all the kind of sort of ideas that you may have in terms of, you know, what is available and how can we use it the best we can. That is what has been driving all these things, you know. The Friendship Bench is one among many examples. You know, in Zimbabwe, well, for those of you, I've been working there for many years now, but the Zimbabwe used to have a reasonably good primary care sector. These days, it's, you know, it's not so great. But there are certain things happening, and it really shows, you know, in terms of lesson for the West, that, you know, the primary care service can be run without doctors. Virtually all primary healthcare clinics in Zimbabwe are run by nurses. So the nurse is a central person in Zimbabwe. But nurses can't do, you know, again, you know, it's a depletion of resources. The nurse cannot do everything in there. So then they have to rely on other, you know, people. And there are many of those, but one of those was the so-called community health worker or lady health worker, because most of them are women, actually. and most of them are kind of sort of in the 50s or 60s, just like myself. It's a reality. So that was the resource that we had available. So we had to sort of, kind of sort of see how we could use that resource, and that led to the friendship bench. But in many other countries, there are similar kind of things. In Brazil, the primary care sector is a lot, much more resource, but not heavily resourced, but much more resource. But again, they have community health workers that are called agents. And then again, there is that. And within all of this sort of, redistributing the resources into new tasks, it's a really interesting situation, because there is a lot of power struggles there. People dismissing others. No, you can't ask a nurse to prescribe, or no, a community health worker must never take responsibility for this and that, and lots of preconceived ideas that you have to challenge, because that's what is available. So that's what I want to talk in my presentation. In facing lack of resources, it's not the end of the world. So the thing is that what do we do when we're faced with that situation? Give some examples of, what we've done. Some of them have been successful. As I said, Abigail mentioned, I want to know what has worked in other places. Well, I can tell you a few things that have worked, but there are quite a lot of things that have not worked. And we know why they didn't work. And I think it's important to know that as well. We learn from failure. So, share with the audience some of those experiences. And perhaps, round up this whole thing, with a little bit of sort of, making people reflect on what can we learn. Because this is not a one-way direction sort of flow of information, it's a byway, it goes both ways. And there's a lot that you can learn. I was last week in the US, I was really surprised to hear that they have a friendship bench in New York now. The whole service, something like, 400 trained people with benches all over New York. I don't know, people do it in different ways. There may be something, there's nothing unique about the friendship bench anyway, If you put it on Google, you'll see that the friendship bench is a concept that has been used in schools here in the UK for at least 30 or 40 years, and some of those benches were actually stuffed with peers, other kids, that took that role. So it's not really, we haven't really invented the wheel, but we've just adapted, some interesting ideas and see, how they work. So that's roughly what I want to say.
Thank you, Ricardo. Anybody want to come in, ask a question, make a comment?
Ricardo, I like the idea that you mentioned of having some time for some dialogue and reflection, because I think we're so into this cycle in ourselves, as everyone has mentioned, that hearing a different perspective might actually be very helpful in moving forward with some new strategies, because I think you're right. We have tried some of these things for a while, and some of them work in certain places and some of them don't work. And so I think having some dialogue with the audience will be very important, because there might be some other things that we have not thought about.
Yeah, I think that, I totally agree with you, Edilma. I think, nobody has got the perfect recipe or solution.
Yeah.
Different things work in different places, and some things, may work in a place at a certain time, but not at another time. So the context is really important when you try to implement things in different places. And people have to, who am I to be to go to a place and propose solutions? So, I can tell them what I've tried, You know, it is for people to use their brains and, you know, scratch their head and say, hey, look, you know, that sounds like the kind of thing that may work in here. I want to hear more about that.
Mm-hmm.
And then, you know, you work with, you know, it's just like what Fiona was saying, you know, you have to collaborate with people, you know, you cannot impose any solutions. I've never seen it work.
I also think that one of the things that we you know, if we're going to look at some other things that we could try, I think the group that we've sort of left out of this conversation are the ministers of health in these countries, because they really are gatekeepers and power brokers, as it were, because they're the frontline people who are making decisions about resources and where to allocate resources. And I wonder if we need to sort of, as a collective nursing community and community of consumers, if we could think of a way to try to go after those ministers of health especially in those low resource countries, because they do make those budgetary, financial, resource allocation kinds of decisions, or at least they're at the table when those decisions are being made. So that might be an untapped group that we might need to make feel uncomfortable.
It's fascinating.
Shame them a little bit.
You say that because, you know, last week I was sitting and having a meeting with the new head of the WHO mental health, who incidentally is a woman. And it's not a doctor, for the first time in the history of the WHO. And she's from Argentina, actually, Deborah Kessel. And we were talking exactly about this, you know, that I want to pin down the minister. And she said the only way you can pin down ministers is that when they have the regional meetings, like in Latin America, they have a meeting at the end of September every year in Washington, D.C., because they have the Pan American Health Organization. And then you cannot add any items to the agenda, but they have something which is called added events or something like that. And then, but it has to be proposed by a government. So just before I came into this conversation, I was sending email to a couple of ministers in Latin America, asking them to put forward a motion for an added event on mental health for the next meeting in September in Washington.
And can I just quickly come in on that? I know we're out of time, Andre, aren't we? So just I think in small countries like Mongolia, well, small population, every time I go there, I meet the Minister for Health. Every time it's a different person. There's political instability, government changes all the time. But I think the key stakeholders are the people who hold the budget, and they're often not the ministers for health. I think in Zimbabwe, I met the Minister for Health already, and I'm not working there. So I think they're representatives, but the power is held often within their civil service or in other stakeholders. The Director for Mental Health Services, for example, in Mongolia holds the national budget. She's immovable and won't be going anywhere, so she's the person to influence. But you're right, I think influencing government is key, and we have to do that. But it's I think it's a lot easier in these countries than it is in ours.
Okay, thank you, everyone. It's been a pleasure speaking to you all. Thanks a lot for joining me for the hour, and to everybody who watched. This video will remain online for posterity, so you can look back and look at our ugly mugs whenever you wish. And the conference itself is happening on the 12th and 13th of September. The hashtag is MHNR2019. We will be live tweeting and videoing and interviewing people and all sorts of stuff. So if you can't make it in person, then do follow online and get your abstracts in. Hey, Ben? Okay, all right. We'll see you again. Cheers, everyone.